السلام عليكم. في هذه المحاضرات we will review the basic neurosurgical anatomy and some neuroradiological anatomy. This is basic for your understanding to the pathological processes of the brain and particularly head injury. So we'll start by reviewing the brain anatomy as you can see from this photograph that the skull bone has been removed except for the suture lines, and this is the front, this is the eye, this is the ear, this is the back, and as you can see this is the pterion, which is the confluence of the coronal sutures with the sequamous sutures, and here is the sequamous part of the temporal bone has been removed. Then we have the superior temporal line which was left, and this is the attachment of the temporalis muscle to the skull. We have the coronal sutures, and then we have the sagittal suture extending from the lambdoid to the coronal sutures here. Frontal bone, parietal, occipital down here, and the temporal bone. If we remove the dura, now we can see the lateral surface of the brain. This is a mid-sagittal cut of the brain tissue, and you can see this is the superior sagittal sinus extending. This is the front, this is the back, this is the superior sagittal sinus extending from the anterior cranial fossa, and more veins will join the superior sagittal sinus and become wider and broader until it joins the trochlea here and the inferior sagittal sinus through what we call the straight sinus to form the transverse sinus. The important thing about this slide that you have to remember that there is a tentorium here which separates the structures of the brain into supratentorial compartment, which contains the cerebral hemispheres, and the infratentorial compartment, which contains the cerebellum, the midbrain, pons, and medulla. In this mid-sagittal cut, we can see the basilar arteries coming in front of the pons and the vertebral arteries coming in the front of the pons, and they join each other to form the basilar artery. In the carotid canal, we can see here the carotid artery coming inside the bone, and then it comes to pierce the dura and become intra-edurally. Also at this middle sagittal cut, we can see that this is the corpus callosum, which is type of commissural fibers which connect the two cerebral hemisphere. It's worth mentioning that in the cerebral hemisphere we have the gray matter on the outer surface, and the rest of it is white matter, and we have three types of white matter: the projection fibers, the association fibers, and the commissural fibers, and the corpus callosum is an example of the commissural fibers. The only place we have gray matter within the cerebral hemisphere is near the basal ganglia, and we will come to this soon. So this is looking at the brain from the front. So this is the eyebrows here, and we can see that there are two cerebral hemispheres, usually separated by a fold of the dura in the middle called the falx cerebri. This is the frontal lobe, and the frontal lobe, you have to remember that it is the largest lobe. It has a superior gyrus, middle gyrus, and inferior gyrus, separated by the superior sulcus and the inferior sulcus. Looking laterally, again, this is the superior sagittal sinus. This is the sylvian fissure, which separates the frontoparietal lobes from the temporal lobe, and the frontal lobe ends in the central sulcus. Here is the central sulcus, and in the precentral sulcus we have the precentral gyrus, which is responsible for the motor cortex. In the inferior surface of the frontal lobe we have the pars orbicularis, triangularis, and pars orbitalis. In the dominant hemisphere, these are part of the speech area. Looking at the inferior surface of the brain, we have the temporal lobe here, and we have this medial structure here, which we call the uncus. And you have to remember this for the trauma lectures, that the uncus, when it is pushed from the outside because of a hematoma or injury or a contusion, it will shift medially and it will compress. This is the third cranial nerve, oculomotor nerve, initially, and this will result in dilated pupil. Then it will compress this part of the midbrain, which is the crus cerebri. And the crus cerebri has the corticospinal tract. And because this is above the pyramid, will result in contralateral hemiparesis. The dark area here is the substantia nigra, and you may recall that this is part of the part of the pathophysiology of Parkinson disease. Optic nerve forming an optic chiasm, then optic tract. This is the fundibulum of the pituitary gland, and this is the olfactory nerve here running on the inferior surface of the brain. Again, a lateral view of the brain showing the amount of arteries and vessels, and if we can remember from the anatomy that the middle cerebral artery runs deep in the Sylvian fissure. We said that this is the Sylvian fissure, and the anterior cerebral artery supplies the medial surface of the cerebral hemisphere. Again, this is looking anteriorly, and this is the beginning of the superior sagittal sinus, and we can see the amount of contributory and attributes of veins that come and drain blood into the superior sagittal sinus. This is looking posteriorly, and again, this is the superior sagittal sinus, and it ends in what we call the torcula, and forming the lateral or the transverse sinus. Looking again laterally, we want you to appreciate the depth of the Sylvian fissure and how far it extends to the level of the pinna of the ear, and again the precentral gyrus, which is the motor cortex, and the central sulcus down to here. This is part of the cerebral hemisphere has been removed, and this is the anterior cerebral artery, which is a branch of the carotid running around the corpus callosum, which is again an association, a commissural fibers. We said that there is a deep matter apart from the one in the cortex, which is deep in the what we call the basal ganglia, and these are the basal ganglia. This is here medially, the most medial part is the caudate nucleus. This is the anterior, if you can see the shadow of a white matter here. This is the anterior limb of the internal capsule, genu of the internal capsule, and the posterior limb of the internal capsule. Lateral to the internal capsule, we have the globus pallidus, putamen, and extremely lateral, we have the claustrum. So again, to recap, we have gray matter on the cortex and in the basal ganglia only. The internal capsule is type of projection fibers, mainly has the corticospinal tract, which by definition of the projection fibers, it is the fibers that transmit signals from one cerebral hemisphere to the lower levels below the cerebrum. That's to say to the spine or to the brainstem. This is another look from superiorly internal capsule, anterior limb, posterior limb, genu. We have the thalamus, and we have the caudate nucleus or caudate nucleus, and we have the globus pallidus laterally. This is the frontal horn of the lateral ventricle. This is the foramen of Monro, the flow of the CSF from the occipital horn, and the frontal horn, temporal horn, down through the foramen of Monro to the third ventricle, and then it flows from the third ventricle to the fourth ventricle via the aqueduct of Sylvius. This is a choroid plexus here, filling the occipital horn, and this can be calcified in adults and is hyperdense on a CT scan. Again, let's look at the ventricles. We have frontal horn, foramen of Monro, and these are the temporal horns with choroid plexus inside of them. So the lateral ventricles is composed of frontal, temporal, and occipital horn in addition to the body. We don't have choroid plexus in the frontal horn. It is mainly in the temporal and the occipital horns. Again, lateral ventricle, septum pellucidum, foramen of Monro on one side and foramen of Monro on the other side, draining CSF to the third ventricle. This is a superior view of the cerebellum. This is where the tent should be, and this is why we have supratentorial structures and infratentorial structures. In the infratentorial structures, we have the cerebellum, and this is the superior surface of the cerebellum, and we have the brain stem. This is the occipital surface or the posterior surface of the cerebellum, and it's worth mentioning that this is the most inferior part of the cerebellum, which we call the tonsils. And when we have increase in the intracranial pressure and the tonsil herniates, this is the part we are talking about. This will come through the foramen of magnum or foramen magnum here and cause further compression on the medulla and the arteries and end by posterior circulation infarction. This is looking anteriorly, pons here, midbrain, medulla, and this is the pyramids, and we can see the different cranial nerves coming out of the brainstem. This is a view of the fourth ventricle from the back after we remove the cerebellum, and it's worth to remember that it is diamond in shape, and the aqueduct of Sylvius is around here. CSF coming from the third ventricles will come and fill this fourth ventricle, and then it will go through the foramens of Luschka laterally and foramen of Magendie inferiorly. When we speak about the blood supply of the brain, we have four main arteries that supplying blood, carotid on each side, right and left carotids, and we have the two vertebral arteries join each other to form the basilar, which terminate in the posterior cerebral artery. The connection between the anterior circulation and the posterior circulation is what we call the posterior communicating artery. This artery is in very close proximity to the oculomotor nerve, and when we have vascular pathology like aneurysm, it will be compressing the oculomotor nerve, and this will result in dilated pupil also. Another view, we have the basilar artery here is formed by joining the two vertebral arteries, and then it will bifurcate finally to the posterior cerebral artery, and then we have the posterior communicating artery and two carotids on each side. This is again the oculomotor nerve. If we have herniation from this side of the uncus, it will come here, compress the oculomotor, causing dilated pupil, compress the posterior communicating artery, causing infarction on the occipital lobes, and finally it will compress this crus cerebri here and the corticospinal tracts, and may result in contralateral hemiparesis. Again, let's talk about the veins now. This is the superior sagittal sinus, as seen from the top. Superior sagittal sinus will drain into the trochlea, forming the transverse sinus, and this is a good view of the tent. It's actual tent rather than a flat structure. So this is the transverse sinus, and then the blood will go to the sigmoid sinus and then further into the jugular. Again, we look into the tentorium, which is part of the dura. So this is the tent, separating the supratentorial compartment, temporal, occipital, parietal, and frontal lobes from the midbrain, cerebellum, and the rest of the brain stem, which includes the pons and the medulla, in addition to the midbrain. Again, another view, superior sagittal sinus, transverse sinus or lateral sinus, sigmoid sinus, and then it goes to the jugular foramen. Anything above here is supratentorial, anything below here is infratentorial. Okay, this is the MRI scan, a T2 sequence, And as you know now that the CSF in T2 sequences will be bright, we are looking at two cerebral hemispheres, the right side, the left side. We can see that the cell size are filled with CSF, and the gyri, which has an outer cortex of gray matter, and this is the corna radiata, or the core, which is mainly white matter. Here we can see the falx cerebelli, which separates the two cerebral hemispheres. Then we have the ventricular system, which is again bright. We can see the occipital horns, temporal horns, and the frontal horns. On the lateral wall of the frontal horns, we have another gray matter here, which is the caudate nucleus, globus pallidus, another gray matter, and we have the anterior, posterior limbs of the internal capsule. This is septum pellucidum, and the CSF flows through foramen of Monro around here down to the third ventricle. And from the third ventricle it goes through the aqueduct of Sylvius to the fourth ventricle here, then through Magendie and Luschka to the subarachnoid space to fill these areas. This is the Sylvian fissure on the right hand side, the Sylvian fissure on the left hand side, and it is both filled with CSF. If we go back again, we have the corpus callosum superiorly. Then we go down to start with the infratentorial structures. So this is the midbrain. This is the crus cerebri. If you remember, we have the optics. This is the carotid artery. We have an optic nerve here, both join each other to form the optic chiasm, which goes backward to form the optic radiation. Then we go down and we have here the pons, fourth ventricle, cerebellum, and this is medially, this is the ancus of the temporal lobe. When there is increased intracranial pressure due to a hematoma on this side, the shift here will cause the ancus to come medially. It will push against the third the third cranial nerve and the crus cerebri. Again, we said this is pons, cerebral hemispheres, and finally we have the medulla here. So this is the gross radiological anatomy of the cranium and the cerebral hemispheres. The tonsils, or the foramen magnum, is here. This is the foramen magnum, the anterior border of the foramen magnum. Again, medulla, and these are the tonsils. When there's increased in the intracranial pressure, this area will be crowded and we will lose the signal from the bright CSF here and here, and it will be all soft tissue, and we will have, this means that we have increased intracranial pressure, and this is the spinal cord. Okay, this is part of the, again, we continue studying in neuroanatomy, but this time from the neuroradiological point of view. And this is an axial CT scan with no contrast. And the reason I'm saying with no contrast, because if we go down where I should see here the middle cerebral artery, the posterior communicating basilar artery, I cannot see them because they are void of contrast, and because when I look at the mucosa of the maxillary sinus, I cannot see any enhancement. When we look at this, let's start by revising the ventricular system. So as you remember from the anatomy review, that the ventricular system is composed of lateral ventricles, which has anterior horn or frontal horn. It has temporal horn, which is this area here, hypotensity, which is normal to be seen like this, And then we have the occipital horns, where there is choroid plexus, and we can see that this is normal calcification of the choroid plexus within the occipital horns. On the lateral, then on the frontal horns junction here, we have the foramen of Monro around this area, and this drains into a slit-like structure, which is this one, which we call the third ventricle. From the third ventricle, the CSF goes down through the aqueduct of Sylvius to the fourth ventricle, and again to Magendie and Luschke. If you recall, CSF will be filling the subarachnoid spaces into the sulci here, and we have these are the gyri, and these are the sulci filled with CSF in the subarachnoid spaces. This is what we call reversed omega sign, and it is usually the posterior to the central sulcus, and this means that this is the motor cortex. Fibers projecting from the motor cortex, we call them the corticospinal tract. They go down as a corticospinal tract to the internal capsule, and this is where is the internal capsule in between the basal ganglia. And if you remember, we said that there is gray matter also inside the cerebral hemispheres, which is the caudate nucleus and the wall of the frontal horns. We have the globus pallidus around here, and we have the thalamus in this area, and this is the anterior limb of the internal capsule, the genu, and the posterior limb of the internal capsule is around this area. Then the corticospinal tract will continue going downward through the midbrain, downward through the crus cerebri of the midbrain, the pons, and then we have the decussation, which happens at the level of the medulla, forming what we call the pyramid. This is the air sinuses, the frontal air sinuses, the orbit, the sella turcica, the optic foramen around here, which transmits the optic nerve, and we have the eye globes, the nasal cavity, maxillary sinuses, and this is the foramen magnum, and this is part here is part of the tonsil, and this is the medulla and the spinal cord. These are the mastoid air cells on the temporal bone bilaterally. Another view is the sagittal views, and in this one, this is a contrasted sagittal view, and the reason why I said it's contrasted, because when we look at the arteries, they are filled with hyperdensity and the veins, and this is typical for a contrasted MRI scan. We remember that we said that the cranium is divided into supratentorial, which has the two cerebral hemispheres, and infratentorial. So this is the tent around here, and it moves forward and attached to the anterior cranial fossa, and it has the cerebellum and the brainstem, the fourth ventricle, aqueduct of Sylvius, tictal plate of the midbrain, tegmentum of the midbrain, the pons, and the medulla here. We have the two vertebral arteries join each other to form what we call the basilar artery here in this area. This is the sella turcica, and we can see the pituitary gland enhancing within the sella turcica. This is the anterior cerebral artery bending around the corpus callosum. This is the deep venous system, the straight sinus, the trochlear. Not sure if you can see or appreciate the shadow of the superior sagittal sinus around here. Okay, and it comes down to the trochlea. Ventricular system, lateral ventricles. Around here is third ventricle, and this is the temporal lobe on the other side. And by this we finish the neuroanatomy and the neuroradiology of the cranium. The spinal anatomy will be reviewed in the degenerative spine disease lecture.